We're going to talk on brain teasers and pediatric infectious diseases. Now, when we talk about brain teasers, there are two issues that come into our mind. Are we going to talk about issues related to the brain, or are we going to really talk about dilemmas that we face in clinical practice? Yeah, so when I was thinking about it, there were two issues that came into my mind. What are the dilemmas that we face in clinical practice? Either we see dilemmas in routine infections. Say, for example, you have a child with cervical lymphadenopathy and you don't know what to do. Should you go ahead and investigate? Should you put in a needle? Should you do FNAC? Those kind of dilemmas. Or you come across unusual infections, which are pretty rare, like say you would come across non-tuberculous mycobacteria. So those kind of infections, and these are the kind of other brain teasers that we see. If I had to list out what are the routine dilemmas that we see, most common is when we have a pneumonia that doesn't resolve. And we are in a dilemma, is it TB? Should we do a CT scan? All those issues. I'm not going to dwell on this because there's a separate panel discussion on this. So this part I'm not going to take care of. Cervical adenopathy. You have a child who comes with lymph nodes. You do a MANTU test, MANTU comes positive. You're in a dilemma whether to start TB or not, treatment. So that also is a dilemma which is again going to be covered. Same thing about somebody who comes with abdominal pain. Somebody lands up doing an ultrasound abdomen, gets mesenteric nodes. I get a lot of referrals with these mesenteric nodes. And they say, shall we start AKT? Those kind of dilemmas. POs always are a dilemma that we don't know what we are dealing with. We tend to rule out typhoid and malaria and dengue, and then we go on to probably brucella would be the next step that we would rule out. And if we reach the end, at the end of that, we don't know what to do. CNS tuberculoma. Somebody comes with a convulsion, focal convulsion. You did an imaging and you found a granuloma. You're always in two minds, is this NCC, neurocysticercosis, is this tuberculoma? Should I start AKT? Should I do an LP? Those are the other dilemmas. Chronic meningitis is always a dilemma. You have a child with meningitis, you don't know whether it's TB, it's fungal, it's viral. Fever with jaundice is another thing. I mean, jaundice we would think of hepatitis A, but you don't expect fever to be there with it. You have a child with dengue who comes with fever and jaundice, but then the fever persists. So those are the dilemmas that we face. And then obviously we have these dilemmas in PUOs where we think, is this autoimmune or SOGIA? Now, I'll give you an example. This is a current scenario. I've not added it into my slide. But I have a patient with Caroli's disease. This child has cyst in the liver and has cyst in the kidney. Now this child started running fever. So the first time he was admitted, we thought it is cholangitis. We gave him antibiotics, he responded. 15 days later, he again came back with fever. Every time he gets fever, he gets CRP, which is sky high. It goes to 200. His counts go high. This has happened in the last 3 months, 6 times. He comes with recurrent fever. We've never documented cholangitis in him. We've never documented a UTI in him. Everything possible was done, 2D echo, autoimmune workup, everything. Now, this time when he got admitted in Diwali, I said, I'm not going to start you on an antibiotic. CRP went up to 300, ESR jumped up to 120. We didn't start antibiotic. And this time we let the fever evolve. And once the fever evolved, we got an ANA positive and we got an anti-CCP positive. So it turned out to be a systemic onset JIA in a child with Caroli's, which you would have not thought of. So sometimes these POs make you wonder, and it's always better to observe the child and let the disease evolve. Because once you let it evolve, you get an idea what's happening. So these are the routine infections and what dilemmas we are facing. But let's take unusual infections. What are the unusual infections that are coming up? Myloidosis coming up, pretty much there in Mumbai right now. Non-typhoidal salmonella. You could get salmonella typhi. But nowadays we go to Chinese restaurants and we go sightseeing all over the globe. So we go to brackish waters, you go to beaches. So you may land up with fever and you don't know what you're dealing with, and it could be just non-typhoidal salmonella. So your typhimurium, your salmonella typhimurium, salmonella dublin. So these are the upcoming. Non-tuberculous mycobacteria. We always talked about Mycobacterium tuberculosis, but you could get MAC, Mycobacterium avium complex. So these are unusual infections. And when you have unusual infections in PUOs, always ask two things. History of exposure to animals and history of travel. Lot of your POs you'll pick up with this history. So if you ask for history of exposure to animals, you'll get a lot of idea. I had a call from a pediatrician. He had a child admitted in the ICU with fever, dengue positive. And the fever was just not coming down. So thinking that it might be associated gram-negative sepsis with dengue, which is pretty common, he had started the child on ceftriaxone initially and then shifted the child on piperacillin tazobactam. Fever just not coming down. He said, can you come and see? I said, it's little, wait for 48 hours, repeat the blood culture, see what's happening. 48 hours later, child still running fever 104, blood culture negative. So I went to see the child. Child in the ICU is stable, just running fever. Finally, I asked the parents, any history of exposure to animals? And they said, yes, we bought rabbits 1 month back. So when you think of rabbits, you think of tularemia. Now tularemia, you cannot diagnose in India because we don't have the ELISA test for it. So we gave him an empirical doxycycline. Fever came down in the next 24 hours. Okay, so sometimes you may have these co-infections and you need to go into the history of zoonosis. So go into, and it's amazing when you take this zoonotic history, you get so many different kind of exposures, parrots, fish, playing with turtles. So these kind of, which you would have never imagined that a patient could be having these kind of animal exposures. Travel infections. I had a call at Nanavati with a child who had these rash, had come from USA. The moment we saw the rash, we said this is Lyme's disease. So it's not necessary what you say is occurring only in that part of the world will not occur here. We are now getting into a global village. So we need to be aware of what infections are common in other parts of the world. So these are the unusual infections. This is probably once in a lifetime that we may see these kind of infections, but we need to be aware about it. Now if I take a case, I told you I'm going to take standard cases that we're going to see. I'm not going to take lymphadenopathy, mesenteric adenopathy, abdominal pain because that's going to be covered elsewhere. You have a 6-year-old boy, he's come with a right focal convulsion. CT scan done shows ring enhancing lesion 7 mm with perilesional edema suggestive of neurocysticercosis. He's given albendazole for 28 days with antiepileptics. 1 year later he again comes back with a focal convulsion. This time an MRI is done. And an MRI again shows the same lesion, smaller in size, and now the radiologist says this is tuberculoma. So the question comes is, this is the lesion that I'm showing you there. Now the question comes is, how do you differentiate between NCC and tuberculoma? So do we have a definite way of differentiating? Yes, we do have. One thing is that if you take imaging findings, then there is a difference between the two. Cysticerca are usually round, tuberculomas are usually irregular. Cysticerca are less than 2 centimeters, may have a scolex. Tuberculomas are usually more than 2 centimeters. Cerebral edema is there in cysticercosis, you will get a midline shift. In cases of tuberculoma, there will be severe perifocal edema and there will be focal neurological deficit, which you don't get in cysticercosis. But again, there's a whole gray area in between. These are two sides, transparent areas, but there's a lot of gray area in between. Now, so if we go by the definition of tuberculoma, this would be a typical tuberculoma, the shaggy, irregular appearance or multiple lesions that are crowded together and causing perilesional edema. NCC, all of you all said we could do ELISA, we could look at NCC at different sites. You have certain diagnostic criteria. Now these criteria are based on absolute criteria, major criteria, minor criteria and epidemiological criteria. And you have a various combination that you can take. Somebody said we could do a biopsy. So if you have a biopsy proven, it's absolute criteria. You have a scolex or you have cysticercus in the eye, then it's an absolute criteria. You have various major criteria in which you take your antibodies or the lesion disappears after treatment or there's a spontaneous resolution. Minor criteria is your positive ELISA in the CSF. The others are pretty much obscure. And epidemiological criteria, India, everyone fits into epidemiological criteria because we are in an endemic area. So if you have to define NCC by this criteria, you have various one absolute criteria, finish, the end. Or you take 2 major, 1 minor plus 1 epidemiological. That's definitive diagnosis. Or you have this gray area again where you have these probable diagnoses. So this criteria again does not help us. Now if we go back to the slide that we had around granuloma, we don't fit into the absolute criteria. We have lesions suggestive of NCC. So we have 1 major, we've not proved the antibodies and we are in the epidemiological criteria. So we would be fitting into probably 1 major, 1 minor and 1 epidemiological. So we are in the probable diagnosis. We can't make a diagnosis here. So next question is, okay, can we try and look for tuberculoma? So can we do a CSF? Question is, the tuberculoma positivity in CSF as a meningitis is going to be very low. So doing an invasive procedure, sending for a gene expert or looking for meningitis is not going to yield you much effect. So if you have an asymptomatic child who's just come with a focal conversion, don't go ahead with a CSF. So any other way to differentiate? Now we've exhausted all our criteria. Any other way to differentiate between NCC and tuberculoma? There is an entity known as MR Spectro. Okay? MR Spectro basically helps you to differentiate a tuberculoma from other granulomas. How does it help? It looks at the various metabolites, brain metabolites. It looks at the lipid peaks. It looks at choline, creatinine, lactate. What it does is, in tuberculomas, the tuberculous bacilli is full of lipid, the cell wall. So in tuberculomas, there will be lipid peaks that will occur on the MR Spectro. There will be increased choline levels, and the choline-creatinine ratio will be greater than 1. So if you get this kind of a picture, you know that this is tuberculoma. So whenever you have a space-occupying lesion, once you do an MRI and you found that, the next step would be an MR Spectro. So that was about differentiating between tuberculoma and NCC. So now this is a typical, we had this patient who came with this huge mass and we don't know what it was, and when we did an MR Spectro, it showed that there was an increase in the choline levels, there was an increase in the lipid, and it was suggestive of tuberculoma. So even though it looked like a neoplasm, it turned out to be tuberculoma. Since we are still at the brain, the other thing is, are we sure every granuloma is only NCC or tuberculoma, or are we dealing with something else? So this was a girl that I saw recently at Nanavati. 11-year-old girl, she's a known case of Fanconi's anemia. She's persistently neutropenic for the last 2 years. She came with headache and projectile vomiting. On admission, she had features of raised ICT and she had no focal neurological deficit. Her imaging was suggestive of an SOL. So you can see this mass in the frontal lobe, huge SOL. She was given anti-edema measures. Now the question is, what is this? How do we investigate this? Again, do we do the NCC? This is not neurocysticercosis. It's too large. So what is this in this child? Is it tuberculoma or is it something else? So here, we have a child who's neutropenic. She's Fanconi's anemia. She's neutropenic. So she's immunosuppressed. Now, in neutropenia with a huge mass, it could be a brain abscess, it could be tuberculoma, it could be a fungal infection, or it could be even a neoplasm. CSF was done, which was normal, chest X-ray was normal, MANTU was negative, CSF gene expert negative, bacterial fungal cultures negative. It could be a toxoplasma in an immunocompressed child, which is negative. Cryptococoma, fungal infection, cryptococcal India Inc. negative. So now what do we do? How do we approach this child? So we've almost practically ruled out TB, but we are on to something else, either a neoplasm or a fungal. Neutropenia, high risk of fungal infection. Which are the CNS fungal infections? Cryptococoma, aspergilloma, or a mucormycosis. And diagnosis is only by biopsy. So can we do something non-invasive? What we did is we sent a beta-galactomannan. For aspergillosis, beta-galactomannan is a good test. You could send it in serum, you could send it in body fluids. So if you have a pulmonary aspergillosis, you could send it your BAL, you could send serum. Just make sure you don't have a child on broad-spectrum beta-lactam antibiotics, because if you have a child on ceftriaxone or cephalosporins or piperacillin, you could get a false positive beta-galactomannan. In this child was not on any antibiotics, beta-galactomannan positive. So we proved that this child had aspergilloma. Question is, do we start amphotericin B or do we start voriconazole? Because we have to cross something in the blood-brain barrier. Earlier days, any fungal infection of the brain used to be treated by amphotericin B. Voriconazole has a good CNS penetration, so you could use voriconazole in this child with aspergilloma and send her home. So this is what we did. We didn't keep her in the hospital, we sent her home on voriconazole. Now brain teasers can go either way, like this cartoon which tells you it's 3 blocks or it's 4 blocks, so it can go either way. I thought we talked a lot about brain, so let's come back to something which we see more common, fever of unknown origin. This is a 4-year-old boy, again I saw in Nanavati, fever for 15 days, no localizing signs, no contact with TB, no exposure to animals, no recent travel. On examination, he has insignificant cervical lymph nodes and he has soft hepatomegaly, nothing else. Now the pediatrician had worked him up extensively. On CBC, he just had lymphocytosis. Platelets and hemoglobin were normal. ESR was 60. Vidal test, blood culture, typhoid dot, malaria, urine, chest X-ray normal. HIV was ruled out, brucella was ruled out, Mantoux test negative, USG abdomen showed only hepatomegaly, autoimmune markers were negative. So as I told you, what we do workup for FUOs, we didn't get anything here, neither did we get anything on the history. So what's the next step that we should do? So what is the likely diagnosis? Peripheral smear did show atypical lymphocytes. So probably here we are dealing with infectious mononucleosis. He had lymph nodes, he had hepatomegaly. How many of us actually pick up infectious mononucleosis? We don't pick it up because we don't suspect it. We always say this is viral URTA. We don't really think of infectious mononucleosis. What are the tests for infectious mononucleosis? We do the heterophil agglutination test, which is very non-specific, or we do antibodies to EBV. Now, EBV is something which has now come a lot into fashion, especially since we talk about transplant and we talk about HLH. So we talk about a lot about EBV. So, but we should know what test to send. So, which antibodies to send. Now, there are three antibodies. We have a VCA, viral capsid antigen antibody, that's IgM, IgG, and we have an IgNA, that's an EBV nuclear antigen. In primary infection, your IgM is positive, VCA, IgM. So when you write to the lab, you have to write VCA, IgM. If it's a secondary infection, you may get an IgM positive, but you get a very high IgG positive. Your IgNA will be positive but low titer. And if a child is harboring EBV, but that is not causing an infection, it's a latent infection, you'll only get an IgG, low titer positive, and an IgNA which is positive. Okay, so that's how we differentiate. Most of the time we are sending EBV when we want to know about active infection. So in that case, only EBV, VCA, IgM is good enough. So in this child, his heterophil test was negative, but the EBV, VCA, IgM came positive. Next question. Now that we've diagnosed this child as EBV, infectious mononucleosis, should we treat him? Usually, if you look at clinical course of infectious mononucleosis, it's usually 3 to 5 days, and that's the reason why most of us don't pick it up, because we never suspect it. It's constitutional symptoms, body ache, malaise, headache, fatigue, followed by fever, lymph nodes, sore throat, hepatomegaly. Sometimes these children may get jaundice, but not usually everyone. In children, infectious mononucleosis is mild, it's just like a viral URTA. Whereas in adults, it's more severe and protracted. Now in this child, the fever has gone on for 3 weeks. Usually we would have expected the fever to subside. In him, the fever has gone on for almost 3 weeks now. He's still running spikes of 103. Can we do anything? We tell the parents, look, he's got infectious mononucleosis, it's going to settle down. But we are scared. If we leave it like that, will he go into HLH? That's our next thing. If we leave this fever unchecked, will he go into HLH? So can we do anything about it? So when would we treat EBV is only when it's going into complication. Okay? And remember, all the antivirals that work on EBV work only on a multiplying EBV. It's not going to work on a latent EBV. So the antivirals that we have for treating EBV are basically your herpes, anti-herpes agents. So we have your acyclovir and your ganciclovir. They both inhibit the EBV DNA polymerase, so they work only on multiplying cells. They don't work on the ones that are latent EBV. Problem with acyclovir is when you take acyclovir, only 10% of it or 20% of it is going to get absorbed. Remaining is not going to get absorbed. And of that, very little is going to reach the cell. Ganciclovir, there's hardly any data on how it works on EBV, and it's more toxic than acyclovir. So you have a new drug which is known as valacyclovir. It's a prodrug of acyclovir. It can be absorbed orally. It's got a very high bioavailability, almost 50%. And then it gets converted into the body into acyclovir. So you get a 50% bioavailability of valacyclovir. Whether to treat infectious mononucleosis with valacyclovir, only few case reports. Nobody's done a randomized control trial to say it works. Why we tried it in this child? Because he was running fever for almost 3 weeks. So we tried it in this child. The day we started, 2 doses later, the fever disappeared. Okay, so my idea of presenting this case was not from the point of view of valacyclovir, but from the point of view of don't forget infectious mononucleosis in your FUOs. FUOs, we always think infection, brucella, zoonotic, reticuloendothelial system, TB, HIV. We think of autoimmune disorders like systemic onset JI, SLE. We think of malignancy. This is the standard. Sometimes we think of otitis media sinusitis, but we don't go beyond that. So keep that in mind, that probably it's infectious mononucleosis. Now, this is something that occurs, a patient does not come to you as an infection, but with a complication. He's a 14-year-old HIV infected boy. He's been on ART for the last 10 years, zidovudin, lamivudin and efavirenz. Now he comes with severe anemia, HP has suddenly fallen to 4.5. He's not in failure. So you suspect this is zidovudin-induced anemia and you change the ART. So he was changed to tenofovir, lamivudin and efavirenz. At that time he did his HIV viral load, which was undetectable. CD4 count was good. In spite of changing his ART, his anemia continued. So now we kept on following up this child. He developed pancytopenia over a period of time. Till now the child is not running fever, he doesn't have any hepatosplenomegaly. Now if we think of HIV with pancytopenia, probably HIV itself is causing it, but we said viral load is undetectable. Probably the drugs were causing it, we changed the drugs. Probably he's getting megaloblastic anemia because these drugs can also cause megaloblastic anemia. So we did a bone marrow biopsy and aspiration. Bone marrow aspiration did show megaloblastic anemia. B12 levels, RBC folate, everything was low. So he started on B12 injections and folic acid supplements. Just to make sure we are not dealing with juvenile pernicious anemia, we did an antiparietal cell antibody which is negative. Even after 2 weeks of this therapy, he's just had no response. His hemoglobin has further fallen to 4.1 and retic is 1.2. What is the cause of his anemia? Now remember, whenever you have an immunocompromised child, in an HIV positive patient, getting your CD4 back to normal does not mean he's still not immunocompromised. You may have a quantitative increase in CD4, but you may still have a qualitative disturbance in the CD4. So they are still having a bad immunity. And they can always harbor an infection without fever. So whenever you have an immunocompromised child coming as pancytopenia, you must do cultures. So whenever you do bone marrow, when you do aspiration, biopsy, send the cultures and send for fungal, TB and bacterial cultures. Because you could have mycobacterium avium sitting there, you could have a fungal candida sitting there, or you could have an unusual bacterial infection sitting there. And mind you, they may not throw fever. So this is not only for HIV, for any immunocompromised child, whenever you have pancytopenia and you're doing bone marrow, send the cultures. In him, the bone marrow culture grew Stenotrophomonas maltophilia. It's a kind of a gram-negative organism. Earlier it was clubbed as Pseudomonas, but now it's got separated from Pseudomonas. And it comes by exposure of going into aquatic conditions. So the next question that I asked him was, did you go to a swimming pool? And he said yes. Okay, so now the next thing is, apart from zoonosis, that's your animal exposure, unpasteurized milk, travel, exposure to different sources of water is important. So this child was started on ceftazidime. I just started him 2 days back on ceftazidime. So I have to see the response to this therapy. But keep that in mind. So one nugget here is that when you have immunocompromised child and you are getting pancytopenia, apart from malignancy, aplastic anemia, megaloblastic anemia, keep in mind infections and send the cultures. So sometimes it's our medicines that cause problems. And we all know the common side effects of common medicines. This is a 13-year-old girl. She's a fibrocavitatory MDR-TB on second-line drugs for the last 14 months. She's on ofloxacin, PAS, cycloserine and ethionamide. Suddenly she comes to my clinic with this rash. I don't know whether this rash is clear, but you can see on her fingers this rash that has come. We stopped ethionamide in this child and started very high dose nicotinamide, 200 milligram per day. 15 days later you see her hands, they're fine. Now can you tell me what this was? Pellagra. And can you tell me one TB drug that can cause pellagra? Common drug that we use. In this child it was ethionamide. It's INH. INH, we give pyridoxine supplementation, but we forget that if the child is deficient in nicotinamide, then the child will end up with pellagra. So INH is one of the commonest causes of pellagra, in fact. If you go through WHO manual or RNTCP manual, they say that whenever you use cycloserine in a child with second line antituberculous therapy, you must give pyridoxine as a supplement. Or when you are using INH in an adolescent age, you must use pyridoxine. Nobody mentions about multivitamins. Why this child got pellagra is usually I keep most of the patients on multivitamins till the time they are on antituberculous therapy. This child had stopped the multivitamins 2 months back and she ended up with pellagra. So that was a lesson for me to learn also, that if I have a child on MDR treatment, I must continue giving them multivitamins till they are on treatment, because they may get various micronutrient deficiencies. So that's another clinical advice when you're treating TB. Make sure that you have all your supplements, nutrition supplements. TB also can cause vitamin D deficiency. TB itself and the drugs itself. In fact, when we did a study, we found that most of the patients get vitamin D deficient on treatment. So nowadays, every 2 or 3 months, I supplement them with vitamin D to just maintain their vitamin D levels. And we know vitamin D is one of your immunomodulators also. When you have these brain teasers, I can't go on with the list. It's an endless list. So whenever we have these brain teasers, we need to actually look at it from a very logical and analytical approach. I always tell my residents that what we have in abundance is actually so uncommon, and that's common sense. Okay, so we need to just think logically with our common sense, and we'll come to some way of approaching these patients. And sometimes the mind just does not know. So if you don't know, you don't think about it. So we need to keep ourselves updated. And medicine is one branch in which we have to, I think, keep on reading till the end of our life. If we stagnate, okay, I've finished my MD and that's the end, then we are going to stagnate. I came across a joke once, that once when we do our MBBS, we think we know everything. When we do our MD, we realize we know nothing. And when we do our super specialization, we realize we know nothing, nor does anyone else know anything. Okay. So we need to keep on reading all the time, and we can't keep on ordering endless investigation. Your patient is going to get fed up and run away. So we need to actually be judgmental in what we are going to, which investigations we are going to do. So that's the end, and thank you very much.